It's all yours, fine.
Okay, so I can start, yeah? Perfect. Okay, so hello everyone. It's really very unusual situations that we cannot communicate normally, but I will try to do my best. It's really a pleasure and honor to be with you, even if only virtually. I wish I could be with you, but it did not happen this time. I was asked to talk about the use and misuse of probiotics in children. What is the evidence? And I know that Mel have already introduced me. It's really a pleasure to be now with Mel, and because we had the pleasure to collaborate together as co-editors of the Journal of Pediatric Gastroenterology and Nutrition. And I'm really very privileged to be invited here. I presume you already know what are the objectives of this talk today, and that by listening to it, you should be able to define and critically evaluate the concept of gut health, and explain the scientific rationale and evidence base for the use of probiotics in pediatric practice, and analyze variation in clinical guidelines for probiotic use. But let me start with something else. Let me start with Oscar Wilde. When I was young, I thought that money was the most important thing in life. Now that I'm old, I know that it is. Why am I quoting Oscar Wilde and this talk on probiotics? Well, because there is a lot of money when we are talking about probiotics. It's a huge market which is growing rapidly with no signs of slowing down anytime soon. But people are asking a lot of questions about probiotics. Probiotics, myth or miracle? Are probiotics really that good for your health? Probiotics, panacea, or just a big fad? And it's not only in lay press, but also in scientific journals like JAMA, that people are asking the questions like what you can see here. Are probiotics money down the toilet or worse? I don't know what can be worse, but anyway, this is a question which was asked in this very important journal. But there's also another question, why there is such an interest in probiotics. And of course, it's because of the interest in microbiota. As one of our Belgian colleagues said, you are not human, you are a walking bacterial colony, or more precisely, you are a walking microbial colony. Because there is huge interest on all these microorganisms that are on us and in us, but especially in our gut. And I'm sure you are very familiar with the terms such as microbiota and microbiome. Those two terms are being used interchangeably, even if they do not mean exactly the same, and they do not mean exactly the same in Europe and in the United States. But generally, microbiota is a collection of microorganisms, including bacteria, viruses, fungi, archaea, which reside in a particular niche, and microbiome refers to both a community and its collective genome. And of course, you probably are aware of all these numbers, like, for example, the number of microorganisms exceeds the number of our human cells. We used to say 10 to 1. Now we are saying 1.3 to 1. But even if it's 1 to 1, it's really that there are really a large number of these microorganisms, again, on us and in us, mainly in our gut. But there are two important questions which people are often asking. The first one is, can we define what is a health-associated gut microbiota? How we can define it? And another is, how can we define another term often used, dysbiosis? And the reason I'm bringing those two questions today is because there were two important papers published recently in Gastroenterology. The first was about how to define a healthy gut microbiome, how to define a healthy gut, and the other one refers to dysbiosis. So let me start with the first one. Where to put the line? Where to put the line and how to define a healthy gut? It's relatively easy when we are talking about a disease. For example, inflammatory bowel disease, Crohn's disease, ulcerative colitis, celiac disease. Then it's relatively easy to say we have a disease. But it's much more difficult to define what we think, what we know, how to define a healthy gut. Is it an absence of diagnosed disease? Is it the absence of disease or digestive complaints, or is it an ideal gut structure and function and optimal microbial composition? So where to put the line? And this discussion, this is not a recent discussion. It started many, many years ago. It's more now, probably takes more time now, or more interest. But the first definition which was used is for probably 2011, but maybe even earlier, but especially 2011, by Stephen Bishop. Okay, so in the same article, there's a number of potential markers of a healthy gut microbiota was discussed, as you can see on this slide, and I will comment on some of those markers. So those markers include, first of all, diversity. We know that at least in adult microbiota, diversity matters. Diversity matters, and that the generally diverse microbiota is associated with health. What is diversity? It's how many diverse types of microbes are there. But it's not only diversity. What else is important? Composition. Who is there? Which microbes are present and in what amounts? Even more important is not only the composition, but also what they are doing. Are they producing beneficial substances like short-chain fatty acid? Resilience is extremely important. Can the microbiota bounce back after stress or change? Can the microbiota bounce back after, for example, the administration of antibiotics? And also stability. Is a microbial community staying balanced over time? It's easy to list them, but much more difficult to define each one of those. And in addition, what is very important is that composition, so who is there, doesn't equal function, so what they are doing. And why composition is not enough? Well, because different people have different microbes. Similar microbe function often means similar health, but not always. There is so-called functional redundancy, so many microbes can perform the same role. And finally, microbe composition alone does not define health. There is a famous saying attributed to Alessio Fasano, one of pediatric gastroenterologists. The gut is not like Las Vegas. What happens in the gut does not stay in the gut. And it's very much true when it comes to microbial metabolites. And on this slide, I summarize some of these key microbial metabolites, such as, for example, short-chain fatty acid, acetate, propionate, butyrate, which are the main energy source for colonocytes, but they also have anti-inflammatory effect. Epithelia contribute to the epithelial health. Secondary bile acid, which contribute to immune regulation by modulation. Tryptophan metabolites, very important when we are talking about so-called gut-brain axis. Vitamins, such as vitamin B or vitamin K, which when I'm talking about those, it's always like speaking almost about the biochemical factory when you talk about the gut microbiota. But each one of them, I mean, they are important, but they are highly variable, and none are reliable as standalone markers. So in summary, I mean, it's very difficult to define what is a health-associated gut microbiota. And equally difficult is to define which is dysbiosis. Dysbiosis, which is often linked to diseases such as inflammatory bowel disease, overweight, obesity, allergic disorders, autism spectrum disorders, and many others. There's associations, there's hardly ever causation been proven, but we are always talking in the context of so-called dysbiosis. But there are many challenges with defining dysbiosis, and this is the second article which was on my list, published in Gastroenterology at the end of the last year. The term dysbiosis suggests an abnormal microbial community, but as I briefly highlighted earlier, there is no clear definition of normal microbiota, health-associated microbiota, and without this clear definition of normal, it's hard to identify what is abnormal. And once again, taxonomy doesn't equal function. Because there might be communities with different levels of alpha or beta diversity and may have similar functions, so they're different, but they function similarly. But there also might be communities that appear identical based on microbial diversity metrics, but may have different functions. So they are similar, but they function differently. So altogether, again, it's very difficult, even if you are using this term very often, how to define dysbiosis. In this article, which is more like a commentary, there's also some suggestions for further microbial research, so that one should study the entire gut, not just stool samples. And most of the studies are based on stool samples. They highlight the need for the use of clear terms, not dysbiosis. My personal opinion is that we may use this term dysbiosis because we really do not have much better term. But what is important is just to be sure that to understand that there is no really good definition of that. To develop non-invasive gut health tests, to create realistic human models, to improve laboratory methods to study microbes, to standardize study methods for reliability, to define what is in microbial products, we'll talk about it in a moment, and focus on long-term studies for insights. So altogether, what I was trying to show you, that there is no clear definition of gut health, health-associated gut microbiota, no clear definition of dysbiosis, and it goes for many, many years, and we are still not there yet. It doesn't mean that people are not working on it. On the contrary, I am part of the International Scientific Association for Probiotics and Prebiotics, and we are now currently working on the consensus statement on the definition of the scope of the term gut health. Whether or not we will be able to come to the better definition to compare to what is in the literature, it's difficult for me to tell now because we are still working on it. But hopefully, we will give some guidance on how to define it and how to measure it. I don't know how it is in your country, but I presume it's the same as in other countries worldwide. The day-by-day microbiota test kits are increasing. And one of the important questions is to use those tests for microbiota testing, to use them or not. They are very often advertised with slogans like understand your microbiome, track your gut health over time, get food and probiotic suggestions, easy, non-invasive sample collection, uses sequencing to examine gut bacteria. More and more of those are available, and at least in my country are quite expensive. But as far as I talk to other colleagues, it's also in other countries. Why I'm talking about this? Because there's an important paper which was published in the Lancet Gastroenterology and Hepatology just 2 months ago, which is an international consensus statement on microbiome testing in clinical practice. And simple conclusion from this very important paper, which was co-authored by almost 80 experts in this field, that there's no solid evidence which supports routine clinical use of this microbiome testing. So it's really nowadays, at least for clinical practice, it's a waste of money because none of the decisions can be made therapeutic or diagnostic decisions can be made on the results of those testing. And the reason is that there is lack of standardization. So for research purposes, yes, but for clinical purposes, not. And we can continue this discussion for a long time, but the patients do not care about our science. What they want to know is, can we cure them and can we prevent diseases? And this brings me to the next part of my presentation, which is on the strategies to modulate the gut microbiota. I summarize those strategies on this slide. Of course, diet is an extremely strong modulator of gut microbiota. Microbiota transfer, fecal or vaginal microbiota transfer, fecal for very well documented for recurrent Clostridioides difficile. It's in the guidelines, but we are not discussing this today. What I would like to focus on is on probiotics, or specifically on probiotics. But of course, it's not only probiotics, also prebiotics, which are, one can call it like a lunch for microbes, substrates for microbes, symbiotics, which are usually a mixture of probiotics and prebiotics, and postbiotics. I call it often life after life, because these are inanimate microorganisms. These were, of course, simplified definition, because there are those also scientific definitions which were proposed by ISAP, International Scientific Association for Probiotics and Prebiotics. And of course, these definitions are on this slide. What is important that if you look at those definitions, you will see that health benefit is always part of the definition for probiotics, prebiotics, symbiotics, or postbiotics. And in addition, we will be not discussing today, but I just want to highlight it, that if you look at the definition of prebiotics, this is the only definition that you not only have a health benefit mentioned, but also the mechanism selectively utilized by host microorganisms. So the only definition when the mechanism of action is included. But as I said, we are not discussing all of those. We are only focusing on probiotics. And probiotics, according to the ISAP definition, are live microorganisms that, when administered in adequate amounts, confer a health benefit on the host. One of the very often asked questions when it comes to probiotics is how to choose a probiotic. And on this slide, I summarize those items which should be considered. First of all, it is genus, species, strain. I will comment in a moment on it. Dose, already in the definition, is that there is probiotics has to be administered in an adequate dose. Safety and quality, I will discuss it later on. And finally, evidence and guidelines. But the first one here is that a genus, species, or specifically strain is important. Why? Because not all probiotics are the same, and each strain acts differently. So what is important, all these numbers, all these letters that are next to the microorganism, which serves almost like an ID, like a passport, are extremely important. So it's not just enough to say, let's use probiotics or don't use probiotics, but which specific probiotic to be used. Once again, not all probiotics are the same. Here, what is important for how to choose a probiotic is evidence and guidelines. And here the problems start. As you are probably aware, there are many guidelines, and the guidelines developed by scientific organizations sometimes do not agree. And it's not only when it comes to probiotics, it's in many other conditions, but of course we are discussing probiotics today. And it's also true for the guidelines developed by societies such as AGA, American Gastroenterology Association, and ESPGHAN, European Society for Pediatric Gastroenterology, Hepatology, and Nutrition. I summarize those guidelines, so they did not address exactly the same conditions, but some of them were exactly the same. But the conclusions they are not the same. And then the important question is why the guidelines developed by various organizations at almost the same time, sometimes, I would say often, do not agree. And this was addressed by my colleagues, two of my colleagues from ESPGHAN. They published this article in Beneficial Microbes last year. And it's a very detailed review, but I would like just to highlight one important issue which has to be considered, why guidelines may differ. There are different approaches. For example, within the ESPGHAN, we do have a special interest group for gut microbiota and gut modifications. And when we are developing guidelines, like the one which I just showed you, we always want to have at least 2 randomized controlled trials on a well-defined probiotic for a given condition. So if there is only one study, whether it's positive or negative, we do not formulate any recommendation. World Gastroenterology Organization has a slightly different approach because it's sufficient to have just one randomized controlled trial demonstrating a benefit, and it will be included in the guidelines. And American Gastroenterology Association had a completely different approach because there was a focus on gathering evidence specifically from North America. So there was not much interest in studies that were not carried out in your region. So this may explain why there are sometimes differences in the recommendation. And of course, the guidelines which are very close to my scientific heart and my interest are those which were developed by SPGAM, Special Interest Group on Gut Microbiota and Modifications, because together with my colleagues, we were able to identify some of the strains and some of the conditions that can be used. Please remember, we always needed at least 2 randomized controlled trials in order to formulate the recommendations. And one of the very well-known indications for the use of probiotics, specific probiotics, is for the prevention of antibiotic-associated diarrhea. Antibiotics have really detrimental effect on gut microbiota, and antibiotic-associated diarrhea, specifically with some of the antibiotics like amoxicillin, amoxicillin with clavulanate, may cause antibiotic-associated diarrhea, but frankly speaking, any antibiotic can cause antibiotic-associated diarrhea. And in our guidelines, we identify 2 strains which may be used if there are risk factors and one considers using probiotics. And these are Saccharomyces boulardii and L. rhamnosus GG. It's a moderate certainty of evidence, but it's a strong recommendation. And of course, we are providing in our guidelines what are the doses of those probiotics which should be given. And this is based on the results of randomized controlled trials. What is the effect size? Because it's always important to know what to expect when we use any kind of intervention. And with the use of probiotics, with proven efficacy, like those which I showed you, you may expect up to 50% reduction in the risk of antibiotic-associated diarrhea, or diarrhea because it's differently defined in various trials, with number needed to treat 9. So this is the effect size that you can expect. On this slide, I summarize some of the questions which are often asked with regard to the use of probiotics for prevention of antibiotic-associated diarrhea. So when should probiotics start? As early as possible. So if you start antibiotic therapy, especially with antibiotics that there is a high likelihood of antibiotic-associated diarrhea, or there are other risk factors, then as early as you start antibiotics, start with probiotics with proven efficacy. How long should probiotics be taken? There is an agreement that throughout the antibiotic therapy, and it's of course based on the results of randomized controlled trials. And the other question, which is often asked, is should probiotics continue after antibiotics? And there is no consensus. However, some experts say that you may extend it for another 7 to 14 days. So these are probably 3 most important, frequently asked questions. Well, this was for antibiotic-associated diarrhea, so well-known outcome, but there are often used other claims about probiotics and antibiotics. And these claims include probiotics improve a disrupted microbiota. Probiotics help balance the microbiota. Probiotics restore good microbes depleted by antibiotics. And then the question is there solid evidence to support these claims? So here we are not talking about the clinical outcomes such as prevention of antibiotic-associated diarrhea, but effect on microbiota. And this was a question that we asked within ourselves, within the ISAP, International Scientific Association for Probiotics and Prebiotics. And this is a recent review that we published in Nature Reviews, Gastroenterology and Hepatology, that we tried to answer this question. about antibiotic perturbed microbiota and the role of probiotics. And the main conclusions from this paper are that there's no doubt on the impact of antibiotics on microbiota. It's undisputable. I mean, there's a lot of evidence that they are very destructive when it comes to the microbiota. There is no doubt that there's clinical benefits of selected probiotics on the prevention of antibiotic-associated diarrhea. Not of any probiotic, but some probiotics do have this effect, and I showed you what is the effect size. However, when it comes to the effect of probiotic on the restoration of antibiotic-disrupted microbiota, those claims which I just listed, it's uncertain. There's no enough evidence with a review of the literature that there is such an effect. And this brings us to the discussion, what would be the mechanism of action that probiotics do prevent antibiotic-associated diarrhea. And this still remains unclear. What is the effect on microbiota composition, on function? We don't have enough evidence, so further research is still needed. So those claims, which I showed you at the beginning, are not really truly substantiated. Another indication that we included in our guidelines is and it's a positive recommendation. It's on the management of acute gastroenteritis. And of course, there is full agreement, consensus in all the guidelines that rehydration and early feeding are the key when it comes to the management of acute gastroenteritis. But one of the limitations of at least oral rehydration solution is that it does not reduce stool volume, it does not shorten the duration of diarrhea, so there is an interest in various antidiarrheal drugs, including probiotics. And in our guidelines, we do have strains that we do recommend and those which we do not recommend. And of course, an interest is mainly on those strains which are recommended. And again, based on the results of randomized controlled trials, we provided those strains and also what are the doses and what is the duration. So as you can see, there are 4 strains, 3 single, and 1 is a combination of 2 strains that may be used for the management of acute gastroenteritis. And then again, the question is, what is the effect size? So what you can expect with when you use a probiotics with documented efficacy. So you may expect reduction in the duration of diarrhea by approximately 1 day. Well, you may say, is it 1 day? Is it really worth something? I can tell you, many, many years ago, I have done one of my very first meta-analysis on probiotics in the management of acute gastroenteritis. At that time, we were looking at all probiotics together, and there was like reduction in 1 day. And I told my husband, who is a cardiologist, who has nothing to do with pediatrics, he was sitting in the kitchen and reading a newspaper. I told him, look, it's just useless. I mean, it just reduces the duration of diarrhea by just 1 day. And my husband looked at me and he said, Hania, did you ever have diarrhea? Because if yes, you would have known that 1 day less in the toilet makes a tremendous difference. And, you know, I'm coming back to this discussion when I am presenting this, because this is this is the evidence, this is the effect size, and the interpretation of this effect size by me and my husband, so 2 physicians trained at the same university, may be completely different. And it's exactly the same for our patients. For one, reduction in the duration of diarrhea is nothing, but for someone else, it is something which may be important. So this is the effect size. And also reduced risk of diarrhea on day 4 with number needed to read. It's 4. And again, there are some frequently asked questions which people often ask, and I summarize 3 of them. When should probiotic administration start? So again, as early as possible. How long should probiotics be taken for the management of acute gastroenteritis? And only those with proven efficacy, 5 to 7 days. So for the duration of diarrhea. And should probiotics be continued after acute gastroenteritis? There is no need for continuation. So I showed you just 2 examples with the effect size, but as you can see, when you look at these ESPGHAN guidelines, there are many other conditions that were discussed, and probiotics which are recommended, and for some situations also probiotics which are not recommended. But there are differences, as I said, between the AGA and SPGAM guidelines, with one exception. Both societies agree that specific probiotics may be used to reduce the risk of necrotizing enterocolitis in preterm infant, even if there were some differences when it comes which probiotics specifically. And of course, in this audience, I don't have to explain that preterm, very low birth weight infants are at increased risk of diseases such as necrotizing enterocolitis, sepsis, feeding intolerances, prolonged hospitalization. And of course, they are also at increased risk of death due to necrotizing enterocolitis and due to sepsis. So here we are not talking about just, reduction in the duration of diarrhea by 1 day, but we are really talking about serious situation and a matter of life or death. So here are the recommendations from our society. So as you can see in green color, those strains, one single and the combination of 3 strains, which are recommended by our society, those which are in red, which are not recommended. And for some strains, we were unable to formulate either positive or negative recommendation. But generally, there are at least some strains which can be used. Conditional recommendation with low certainty of evidence. And again, what is the effect size? It is always important. So stage 2 to 3 NEC risk is reduced by 30 to 50%, with number needed to treat 33, and mortality risk, which is reduced by 23%, with number needed to treat 50. I already showed you on a number of occasions, this number needed to treat and number needed to harm. And you are probably aware, number needed to treat is the number of patients you need to treat to prevent one additional bad outcome, like, for example, death or necrotizing enterocolitis. And number needed to harm signifies the number of patients who must be treated before one experiences harm. And we want, it's extremely important in clinical practice, and we want to have a number needed to treat as low as possible and a number needed to harm as high as possible. And I was showing it for good reasons. And I also would like you now to think about those number needed to treat and number needed to harm, and compare to some other numbers. Statins for myocardial infarction for 1 year. Number needed to treat is 217. Number needed to harm, 21 for muscle pains. But for probiotics, such as Saccharomyces boulardii, which I discussed for preventing AAD, LGG for preventing AAD, 10 to 13. For probiotics for preventing necrotizing enterocolitis, which I just discussed, number needed to treat is 33, and number needed to harm is more than 10,000. But still, there is no discussion about the use of statins, but a lot of the discussion about the use of probiotics, especially in preterm infants. And of course, it's not fair to compare all this number needed to treat because there are completely different interventions, studies, different outcomes. But I just wanted you to think for a while on the interpretation and the whole discussions that we have on probiotics. But there is an important issue and a good reason that we are discussing number needed to harm is in the context of probiotics, because one important issue for any intervention is, of course, safety. And safety of probiotics is something that is being discussed, particularly in the context of preterm infants. And of course, in medicine, zero risk does not exist. Probiotics are generally safe, and this is one of the recent reports which was published by Irish Food Safety Authority. But there is a risk of a potential risk of infection due to probiotics. And this is particularly important in the context of vulnerable populations such as preterm infants. In 2023, Food and Drug Administration issued a warning following the death of a preterm infant who was given a probiotic registered as a food supplement, not registered for the use in preterm infants. And and issued this warning, providing important information to healthcare providers on the use of probiotics in preterm infants, calling attention to the risk of invasive sepsis, citing American Academy of Pediatrics, calling attention to the fact that there is lack of FDA-regulated pharmaceutical-grade products, on conflicting safety and efficacy data with potential for harm, and also stating that current evidence does not support routine use in preterm infants. There's a lot of discussion following this FDA document in Europe, and I also understand in your country. And at least in your country, this resulted in a very dramatic reduction in the use of probiotics in NICUs. It did not happen in Europe, but it did happen it happened in your country. In Europe, on the contrary, we do have this food supplement, which is also in our ESPGHAN guidelines. And in many European countries, probiotics are being still used in NICUs, but not in the United States. And there are two reports which are documented this reduction in the use of probiotics. So this brings me to the important discussion about the quality of probiotic. And the question, is probiotic quality a concern? As a matter of fact, and it's very much true, that most products are registered as food supplements. And there are common quality issues which include, and this comes from our ESPGHAN document, missing strains, contamination, pill-to-pill variation, lot-to-lot variation. One of the former studies showed that in only one of 16 food supplements did the label accurately reflect the actual content. And following these reports in the literature within the ESPGHAN, already a few years ago, we published this call for improved quality control, that products prescribed for specific clinical situations and for use in vulnerable populations, such as infants and children, should be subject to more stringent quality control procedures. But the only thing that we as a society can do is to publish a call, because we do not have resources to provide such a quality control. It has to be done at the national level. By the way, I showed you this disturbing data on the really poor quality of probiotic registered as food supplements, but there is very recent report evaluation of label accuracy in commercial infant probiotics in US. And the conclusion from this paper, and also in the comment which was accompanying this paper, is that there is improved label accuracy compared when it comes to infant probiotics compared to probiotics for adults. So this is extremely important information. Most tested products contain the bacterial strains declared on the label. There was greater composition variability in multi-strain products compared to single-strain products. There were no pathogenic bacteria detected, but fungal DNA was found even if without confirmed viability. So important data from the United States. But there is another important discussion, which is an important question: can pharmaceutical-grade probiotics fully eliminate the risk of sepsis? And the answer is there is no full guarantee. This was addressed in our the document which was developed by ESPGHAN, European Society for Pediatric Gastroenterology, Hepatology and Nutrition, together with representatives of parents of preterm infants, European Foundation for the Care of Newborn Infants. And in our document, we stated the pharmaceutical-grade product, they will result, no doubt, in stricter quality control standard. They will ensure correct strain identity. They will minimize contamination risk. However, when it comes to inherent sepsis risk, it remains. Probiotic sepsis can be caused by factors unrelated to product quality, such as intestinal translocation or catheter contamination. And in the same document, we also highlighted the importance of parents. And that's why we invited this representative of parents to be part of this document. So that respecting a parental rights in decision-making is extremely important. We do not recommend that all very preterm infants must receive probiotics, and the recommendations are conditional, but we do suggest that every neonatologist should be prepared to discuss this option with every parent. Of course, it applies to any other intervention, but this was here specifically when it comes to the use of probiotics in preterm infants. But this discussion is likely to continue. There is now the first trial investigating the effects of live biotherapeutic products in very low birth when infants has been completed, so the connection study. And it's a large randomized controlled trial with more than 2,000 preterm infants, including very low birth weight infants. This study showed, it's not published yet, it's under peer review, but it showed that, but it's already presented at various meetings. It showed there was no reduction, statistically significant reduction in the risk of NEC. However, there was reduction in the risk of mortality. So this discussion will definitely continue. And it will continue, and I'm going back again to this ESPEGAN and document that there's probably room for both, but in our opinion, abandoning evidence-based high-quality products currently available while waiting for pharmaceutical-grade probiotic drugs will cost many lives in the coming years. And there's also an important discussion about the costs which are related. Food supplements, at least in Europe, probiotic food supplements in Europe are relatively cheap. So let's say it's about 10 to 15 euros or more or less US dollars, while pharmaceutical grade products are very likely that they will cost a few hundred dollars. So not every setting, not every hospital will be able to pay such amount of money for the intervention. So again, the discussion will likely to continue. Okay, this is attributed to George Bernard Shaw. Science never solves a problem without creating 10 more, and it's probably very true for the topics that we are discussing today. And there are many questions that I put some of them here on this slide, but I am sure that you have many more. And the examples of those questions include: how do we accurately determine which probiotic strains are effective for specific conditions? And even more important, how to identify probiotic strains for clinical trials, because nowadays, very often, it's not based on mechanistic studies, but simply because some of the products are available. What are the precise mechanisms by which probiotics act? We know very little. And one example was with which I showed you, those claims on probiotics that they modify microbiota, and we don't really have good evidence to that. How can probiotic recommendations be personalized based on individuals' microbes, genetics, or health status? Or will we reach a point where probiotics are prescribed based on microbiome sequencing? A lot is happening in this direction. I mean, definitely machine learning will help probably to identify. It's not easy, but in a long run will help us to identify those subgroups which are more likely to benefit from modifications of gut microbiota. That's what we are doing currently. Can probiotic consistently improve outcomes in extraintestinal diseases? Here in my presentation, I mainly focused on gastrointestinal diseases, but there are many others which are being studied and we are being discussed, and many more questions. Okay, the audience is likely to remember only 3 things from each presentation or speech. So I have 3 key messages from you. So what microbes do matters more than who they are. So the function seems to be more important than their classification. Probiotics may support disease prevention or treatment, but they are not essential. Use should be evidence-based and tailored to individual needs. And probiotics effects are strain-specific, so please do not extrapolate data on the efficacy and safety to other strains. And my closing slide is: make sure you have finished speaking before your audience has finished listening. I did my best. And I thank you very much for your attention. Thank you. Now I wish I can hear you. Okay, maybe I have some questions here. Okay. Hi, Mel.
Everybody can hear you now.
Excellent.
A way to get rid of the echo. That work? No. Maybe. Anyway, Hania, thank you. You got very nice applause here.
Thanks a lot. Thank you very much. I really regret so much that I cannot see you and that I cannot hear your questions. And I can only hear echo.
Does anyone have? Andrea.
I can only hear echo.
We're putting the questions in the Q&A.
Okay, perfect. Okay. That would be probably easier. Oh, okay, I can see. Thanks a lot. Thank you very much for all these kind words. Okay. How do you suggest people get access to probiotics for patients in the outpatient setting? Well, it probably depends on the country, because for example, in Europe, I mean, there is no problem for the patients to get probiotics. Or I would say the problem is the overuse of probiotics and probiotics with no documented efficacy. This is what I would say is a major problem, at least in Europe. Role of probiotics in immunocompromised patients like liver transplant. That's a liver transplant patients. Any data, is it safe or risk for translocation? This is a very important question and no one single answer, because I mean, immunocompromised patients, these are at high risk of sepsis, probiotic sepsis, and it really very much depends on the patient. So really you have to outweigh the benefits and the risk. But in many of those patients, I would probably like with preterm infants, I mean, the risk is here. So there is no one single answer to this question. Is there opinion BSL for the treatment of ulcerative colitis? We usually do not use the commercial name, but indeed, this is one of the probiotics. So combination of 7 different strains, which is in the guidelines, also ESPEGAN guidelines for the treatment of ulcerative colitis and pouchitis specifically. I cannot see more questions.
Hania, can you hear me?
Yes.
Are there any discussions about using the metabolome in the gut versus focusing on the bacteria?
There is some discussion and there is some studies as well, but the problem is that laboratories are using really different methods. It is very difficult to compare the results from one lab with the results of another lab. So it's not that we can make like solid conclusions based on what is published at the moment. Oh, how do you reconcile the great importance of bacteria functional aspects with studies that focus on the Okay, thank you for your talk. We are studying dysbiosis in adolescents with malnutrition secondary to eating disorders. I have been surprised by the lack of standardized approach, attention to dietary intake. And other societies that are As a matter of fact, there is a recent paper published by my colleagues from ISAP, which specifically look at the role. You're absolutely right that the diet is extremely important and was not properly considered in clinical trials until now. The study was published, if I remember correctly, Nature Microbiology. I think the end of the last year, and it's really specifically look at the role of diet, which should be considered. I'm quickly trying to find the probiotic. Okay, the reference. Because you are absolutely right, the diet was neglected or not considered in previous studies. So this was published. Let me have a look. This was published Nature Microbiology 2024 in November. And the title is Design and Reporting of Prebiotics and Probiotics Clinical Trial in the Context of Diet and the Gut Microbiome. And they also provide, like some recommendation what should be included in those trials or how it should be addressed. Whelan is the first author, Nature Microbiology 2024. Extremely important question. So even if in randomized control trials, this is something that has to be considered. And another question which I have here, I see there is a frequent use of probiotics in irritable bowel syndrome, both in constipation and diarrhea variants. Do you have an opinion? Yes, it really depends very much. We are talking about children or adult population. In adults, there are probably 50, if not more, randomized control trials which use various probiotic strains for the management of irritable bowel syndrome. Some of them are in European guidelines. In AGA, the recommendation is to be used only in the context of clinical trial. In our European guidelines for pediatric population, we recommended, it's a conditional recommendation, but we recommended the use of LGG and Lactobacillus reuteri DSM 1793938. So this was in our guideline. And now the next question is about how do you reconcile the greater importance of bacterial functional aspects with studies that focus on distinct strains? I would say complementary. It's not contradictory. I would say why there is a growing emphasis on function, strain level specificity remains crucial because different strains of the same species can have very different functional capabilities, and many health effects observed in clinical trial are really strain dependent. So complementary, not contradictory, I would say. No more questions.
So I'd like to thank you for a wonderful talk. And
I'm just checking if there are, yes, I answer all the questions. Okay.
Can you hear me?
Yes, I do.
Okay. So I just want to thank you again for a wonderful talk, and also thank the Bramham family for supporting this talk.
Thanks a lot. And, thank you very much, everyone. Really.
Have a good night.
Thanks a lot. Thank you very much. Thank you.